Hello and good evening. I can see we are well over 340 participants. Good evening and karibuni sana to our webinar today. Our webinar is on metastatic castration, resistant prostate cancer, and our speaker today is Dr. Njoki Njiraini. Dr. Njoki is a consultant clinical oncologist at the Nairobi Hospital. So I'm going to read a few ground rules before we start our webinar. First and foremost, PSK thanks you for participating in this session. Please make sure you're muted during the entire course of this session. Feel free to ask questions via the Q&A tab. It's at the bottom of your window. The questions shall be addressed by the presenters on the Q&A tab. For PSK members, if you haven't already done so, please subscribe to the event on the PPP portal. That way you can get your CPD points. Remember, CPD points are only awarded to paid up members. For KPA members, the list shall be shared with the officials for the rewarding of CPD points. And for your attention, this session is being recorded and will be uploaded on our PSK YouTube page. I'm doing the welcome and opening remarks. My name is Ivy Ratemo. I am the postgraduate management trainee at PSK. Our presenter today is Dr. Njoki Njiraini. She'll have her moment after this. We'll have a Q&A session after the presentations. You can type your questions on the Q&A tab, and we can also have a live Q&A session where Dr. Njoki will address some questions, and then we'll have the closing of the meeting. Yes, karibu sana, Dr. Njoki. I will now stop sharing my screen so you can take over. Karibu sana and asanteni for joining.
Thank you for the warm welcome. Just give me a second. It's always interesting speaking to the pharmacists, and I hope we'll chat about metastatic castrate-resistant prostate cancer, and then you can always ask your questions and we'll be able to answer as much as we can. Again, I repeat, I'm not a pharmacist, so I'll try to keep it as light as possible. In terms of my training, I have nothing to declare. So in terms of our outline, we'll go through a background, some factors to consider in terms of metastatic castrate-resistant prostate cancer. What's our rationale for therapy? How do we sequence our therapy? What the big, I think, elephant in the room is that what are the cost implications? Because I think this has a big implication in terms of which therapy are we choosing for patients, and we'll quickly go through a case at the end of the presentation. So if we think about the disease continuum in prostate cancer, is that cancer of the prostate starts as localized disease, and over a period of time, the patient will range from being asymptomatic to getting symptoms, from non-metastatic to metastatic, from castration sensitive to castration resistant. And I think we always have to think about this continuum when we're thinking about prostate cancer patients, is that they will live for long, and most of the patients actually pass on not from the cancer of the prostate. Interestingly, when you're diagnosed with cancer of the prostate, only about 3 in 100 patients will die from their cancer of the prostate, but patients will pass on from side effects from the treatment that we give them. So we also have to put that into consideration. Secondly, is that most patients will start with sensitivity to androgen deprivation therapies. That's why they're castration sensitive before they become castration resistant. Now, if we then think about, again, that continuum from when we start the patient on ADT, the median time to progression after ADT is traditionally recorded as about 2 years, but this is when most men will stop responding to the treatment. And we start with patients who have a diagnosis, they have a PSA, they have a biopsy, they get their local treatment, the PSA goes down, and then they get what we call biochemical failure, which is noted as a rise in PSA. Now, for patients with non-metastatic disease, this median time to progression is about 33 months, while for those ones with metastatic disease, it's 15.9 months. And I think this is important to when we are counseling, when we are talking to the patients. And I think pharmacists play a very big role, because you might sometimes end up spending more time with the patient than sometimes some of the doctors do. And this information will be important, especially for the patients, whether they are metastatic or non-metastatic. Now, the definition of castration resistance is that you have a persistently rising PSA while on hormone therapy or surgical castration, and you have testosterone levels within castrate levels of 50 nanograms per deciliter. Now, depending on which side of the Atlantic you sit on, some people might say that it's a rising PSA noted on 3 sequential PSA readings that are more than 3 weeks apart. Some will even give it a month, but those are small details that you can hash out. So if someone has a PSA that is rising, then we're already concerned that you may be getting to castration resistance. Then in terms of the disease progression, is at the first time that the PSA goes up, most of the patients will have non-metastatic disease. But we know if we're not able to control the disease in that area, then they will still continue having a rise in PSA with metastatic disease. And I think this distinction then determines what sort of therapy we are going to offer some of the patients. So if we go back to the basics, we remember the hypothalamus pituitary adrenal axis, and this forms sort of the basis of management of cancer of the prostate, because you remember that from the pituitary you get LH, FSH, and that goes to the testis, you get testosterone being formed, it gets changed to dihydrotestosterone, which is the active form, and it actually produces, it goes down into the cell, into the DNA, and starts with a cascade of production of some of the proteins that we see. And we know that this stimulation is what cancer of the prostate is heavily dependent on. However, we know that castrate-resistant prostate cancer is not hormone refractory. And castrate, you see, because most people will think that because you're castrate-resistant, it means the cancer is not responding to the hormone therapy. It is still responding to the hormone therapy. It maybe has developed other mechanisms, like we see that the cells continue to grow despite the fact that you're having hormone suppression, which then means that even for patients who get castrate resistance, we still need to continue on their hormone therapy, because it means there's still some part of whatever metastatic disease they have that will still respond to the hormone therapy. But then the androgen receptor remains one of the cornerstone items that we look at in terms of managing cancer of the prostate. And some of the things that lead to resistance are things like the androgen receptor amplification or mutations. You get things like coactivators and co-suppressors of the androgen receptor. And then you have altered steroidogenesis. And this forms the basis for why we use some of the therapies that we use for castrate-resistant prostate cancer. So even if we're thinking about how we look at approaching the patient, we look at some of the laboratory markers. So for those of you who maybe have worked in an oncology unit, you'll always find in any MDT, we're always talking about what's a Psa doubling time. And this, I think we'll delve into a little bit of details because it has a lot of bearing in terms of which patient do you select for what therapy at what point. The other marker that we look at is LDH, which is a marker of volume of disease. Alkaline phosphatase as a surrogate of bone health and also for metastatic disease. So then if you're looking at your patient, you also have to assess what are they symptomatic from their disease? Are they asymptomatic? What response have they had to the previous lines of therapy? Because remember, someone who's castrate resistant, as I showed you, most probably they've had some form of treatment prior to that. So we have to take that into consideration. Now, the thing that has come up maybe in the last 3-4 years is we tier the patients into what is high volume or low volume disease, and we look at that in detail. Do they have visceral disease or not? Because the patient who has bone-only disease is managed quite differently from someone who has lung or liver disease. Again, other medical history. And I think this is very important because our patients tend to be older. They have comorbidities like diabetes, hypertension, hypercholesterolemia, and the interplay between the medication that we are giving with the side effects, or, you know, you're practicing now polypharmacy. When do you stop your antihypertensives because you're getting low blood pressure because you're having diarrhea from abiraterone? Or because you're on Zoladex, do you stop your hypercholesterolemia, or do we increase the dose from the 20 milligrams of atorvastatin that you're taking? Again, there are other disease characteristics that we look at because cancer of the prostate is not equal. You can have the traditional acinar adenocarcinoma. However, we have neuroendocrine differentiation, we have anaplastic features, and those are patients who maybe we need to select out before we go through that whole paradigm. So if we think about the disease volume, it is the most powerful prognostic factor for overall survival. And when you're talking about cancer, overall survival becomes a big deal. I know in our clinic, it's not maybe one of the things that we discuss about, but it must come to the forefront because then you're looking at what is the overall survival for this patient. Now, the first time we ever documented that there was a correlation between disease extent and overall survival was when we divided the patients into minimal disease, meaning they had disease in the axial spine, in the pelvic or other lymph nodes, vis-a-vis those patients who had metastasis to the ribs, the long bones or viscera. And that was clear that patients who have visceral disease actually live a shorter period of time, and this might be because of the compromise that they've had or the burden of the disease. Now, for patients who had had bilateral orchidectomy and flutamide, the ones who actually had flutamide did better if they had minimal disease vis-a-vis the ones who had extensive disease. And then the MD Anderson then looked at, in terms of the bone metastasis, is there a number that we can look at and say if you have more than 4 or more than, so for them, the MD Anderson was more than 3. I think currently the ESMO and NCCN guidelines looks at 4 bone metastases, and that sort of formed the basis for dividing the patients into low volume and high volume disease. Now, if we look at how do we find then this metastasis? So then not all diagnostic tests are equal, and I've put PSMA PET at a corner there because I think even in our country, bone scan is only available in one institution. We don't have 18 fluoride choline PET CT or the sodium fluoride PET CT in the country. We have the whole body MRI or the DWIBS, which is on your extreme right. And again, the sensitivity and specificity of picking up metastatic disease depends on the test. So right now, I think we're relying more heavily on using the PSMA PET to determine whether someone has metastatic disease. And again, if you don't find the metastasis, then you may classify somebody as having low volume disease, while in essence, they have high volume disease. Now, we go back to the basics. So all the agents that we're talking about then work on our androgen receptor. Now, one of the agents that we have is abiraterone, which selectively and irreversibly inhibits the CYP17 pathway. And so you inhibit production of the testosterone precursors. So in theory, again, this is a magic drug, because then what you're looking at is that you're not being able to make any other testosterone from any other source once you've blocked your hypothalamus pituitary adrenal axis. Then come in the second generation androgen receptor blockers like enzalutamide or apalutamide. And again, these ones compete with the androgen receptor. They block the activation of the intracellular cascade that happens once you get the androgen receptor and testosterone binding, and it inhibits that nuclear translocation and DNA transcription, which then is still the downward cascade if you block the androgen receptor with the traditional androgen receptor blockers. However, financial challenges become an issue, especially when you're talking of a drug like apalutamide, which I think in this country, very few patients have been able to get it, enzalutamide for some of the patients, but not just cost in terms of finances, but cost in terms of the side effects. So if you look at some of the side effects, especially for enzalutamide, like fatigue, so most of the patients will tell you if you've been on androgen deprivation therapy for more than a year, then the tiredness that they get actually is worse. They're already having hot flashes because of the ADT. They are going to have issues with, in rare occasions, some can have seizures, they can have hypertension or headache. Apalutamide, again, the same thing, fatigue being the main one, hypertension, rash, diarrhea, and nausea. The falls and fractures, I think that one is in consideration together with the bone health that we'll talk about as one of the other things that we need to consider when we are managing these patients. But it doesn't get that easy. So in that paradigm that I'd put before for our patient who will go through their cancer journey is that we have different agents. And I think the one agent that changed sort of the face of how we manage castrate-resistant prostate cancer was docetaxel. So if you look in terms of the time frame, we started with docetaxel here, which was at the point where patients were metastatic, castrate-resistant. And then because of the benefit that was found, then docetaxel has made the crossover into castrate-resistant, non-metastatic disease. Other agents like enzalutamide or radium-223, abiraterone have also made the divide so that we are using these agents even earlier than when we started using them. Again, agents like cabazitaxel, that one comes later, and we'll talk about that in a few minutes. So then if we think of why then these patients get castrate resistance, is that intracellularly you have activation of these protein kinase pathways that we know about, which then leads to your transcription and translation within the nucleus. However, you have gain, especially I'll highlight this one on androgen receptor amplification and androgen receptor gain of function mutation, which is where a lot of research is going into, because the thinking is that you continually keep hammering this androgen receptor over a period of time with your androgen receptor blocker, and you've withdrawn the testosterone. So then, because oncogenesis or in cancer biology, we learned that tumors then will actually have other gain of function mutations, which has been found to actually be one of the things that we maybe need to be thinking about in terms of when you put this patient on androgen receptors for a long time, then we have to anticipate that they will actually get resistance at one point. Again, remember that there are this pathway is not always androgen receptor dependent. So you have androgen receptor independent pathways. And this is why I say that even though you have to target the patients who are getting resistance, you still need to continue on your androgen receptor blockade. Now, if we think about the patients with castrate-resistant prostate cancer, then the roadblocks for them, in oncology, we think in algorithms, because then you sort of divide your patient depending on where they are. So you have a patient on androgen deprivation therapy, PSA is rising. If it is rising and the serum testosterone is less than 50, then they meet the criteria for castrate resistance. Then depending on whether they have metastasis or not, you divide them into two different categories. And I think this is where we are focusing our energies on this evening. So if then we look at the NCCN guidelines, and it gets even better, they bring in this aspect of PSA doubling time. And I said we'll talk about this because then for patients who have a PSA doubling time of more than 10 months, it means that the growth or the increase in their disease burden is lower. So those are patients who you can change to another hormone therapy, or you keep them on the same hormone therapy and you watch them. If the PSA doubling time is less than 10 months, then we have to change tact from whatever treatment that we were giving when they develop the castrate resistance. But what is so important about this PSA doubling time? And again, this is a marker that we use for patients with confirmed cancer of the prostate, and especially when they've been on follow-up with metastatic prostate cancer. So we can use it to risk stratify our non-metastatic castrate-resistant prostate cancer patients. We can use it as a guide to guide us on what imaging techniques we're going to use and what is the therapy that we're going to use. So the patients who are classified as low risk is they have a PSA of less than or equal to 2 nanograms per ml and a PSA doubling time of greater than or equal to 10 months. Now, this would be the ideal patient that you always have. It's not always the case, because most of the patients come with PSAs of 100, 400, and a PSA doubling time of, if you actually look, it's 2 months, which means there is some cells somewhere that are sitting that are producing all this PSA. And if you look, is that the patients with a shorter threshold or a shorter PSA doubling time, their relative risk of metastasis or death is higher. And so we can risk stratify the patients like that. Now, if we go back to where we started with now chemotherapy, the TAX 327 trial, which was published in the New England Journal of Medicine in 2004, looked at patients who had never had chemotherapy, because this was the foundational paper that gave us the basis for use of docetaxel in prostate cancer. So then the standard of care was mitoxantrone at 12 milligrams per meter squared every 3 weeks. They had 2 dose levels of 75 milligrams per meter squared and docetaxel at 30 milligrams weekly, together with prednisone at 5 milligrams oral per day. Now, of note, if you look at the survival curves, the hazard ratio for death was 0.76, but the absolute overall survival benefit was 2.9 months. And based on this, we got FDA approval, EMA approval, and the benefit for this was that the patients had improvement in pain threshold, the drop in PSA levels, together with quality of life, because that was the biggest thing for these patients who at that point in time did not have any other agent that we're using when they get metastatic castrate-resistant prostate cancer. Over time, then newer agents have come into play. So we have things like cabazitaxel, which is another taxane, and that they compared again with the then standard of care mitoxantrone, hazard ratio 0.72 with a very significant p-value. That was a TROPIC trial. Abiraterone has had 2 trials that have been done, which is a COO301 and the COO302. And again, there was benefit, but remember at this point in time, there was no other agent. So I think if these studies were to be done now, we would not have a placebo arm because you have another standard of care. So we'd be testing Abi and prednisone vis-a-vis docetaxel. And I don't think with the evidence we have, that is a trial that will see the light of day. Again, hazard ratio of 0.74. And this was all after the patients had had docetaxel. So there was still benefit of giving them your abiraterone or your second generation androgen receptor blockers. Now, radium-223, I've put here, it's one of the bone-seeking agents that we have, and specifically for those patients who had bone-only disease. Remember when you were saying we're stratifying the patients into high volume or low volume, then the patients with bone-only disease actually benefited from radium-223. The biggest issue with radium-223 is the cost. I think it costs about $2 million to bring that into the country. Now, in the pre-docetaxel era, which is now where we are, where, as I said, abiraterone has crossed over the threshold to enzalutamide into where we have non-metastatic castrate-sensitive prostate cancer. Then the AA302, which was for the abiraterone, had an overall response rate of about 62%. And in the PREVAIL trial, where we looked at enzalutamide, hazard ratio of 0.76 with a very significant p-value. However, remember now, because of how that paradigm from the time of diagnosis to when you get castrate resistance, some of the agents have crossed over, then you can see how some of this might be what we are talking about now, because some of the patients, before, by the time they get castrate resistance, they've already had some of these agents, and it changes even, which then brings to us why we are having more murkier waters. So then we needed to figure out what were we going to do to these patients once you've had upfront docetaxel, and then when you had hormone sensitive disease. So what is next? So then they looked at these patients in terms of response, where they re-challenged the patients again with either getting docetaxel or getting abiraterone. And they divided the patients into two equal, balanced among the arms. And what they found is, for those patients who had now failed and they were treated with docetaxel again, the PSA response was not as good. Actually, the patients who had a decrease in the PSA, because that was a marker that we use again in monitoring these patients, it was not as good. But for patients who then had docetaxel and then were rechallenged with abiraterone or enzalutamide, the response to PSA was very good. And this PSA variation was, because it's one of the most sensitive markers that we use to monitor for response in cancer of the prostate, then it remains now one of the things that we're actually advocating for the patients who maybe have had docetaxel when they are castrate sensitive, and then they get castrate resistance, then we may need to introduce things like abiraterone or enzalutamide. However, when we talk about getting an agent registered, or we start using it in clinical practice, we always look at an overall survival. And I put this with tongue in cheek for one or two reasons. If you look at the median overall survival, this is in months. So we're talking of 4.1, 4.6, 4.4. Remember, again, from statistics, that median overall survival means it's like in the middle. So there are patients who will do even really well. There are patients who will not do very well. And please remember that I showed you the groundbreaking TAX327 trial that was done with docetaxel was approved with only a median overall survival of 2.4 months. So that's where we are coming from, where now patients are getting even better median overall survival. So when you're canceling them, then you tell them maybe this drug will buy you 6 months of overall survival, additional overall survival benefit. However, if you look at the patients who are chemotherapy naive, meaning they've never had any chemotherapy, versus the ones who've had chemotherapy, please look at the numbers on the end. And I'm going to highlight the AA302 and AA301 in terms of the overall survival. And again, remember, as I told you, these may be studies that may not be done now because the control arms were placebo. So that might not be one of the things that we look at. But again, you're looking at an average of 5 to 6 months for most of these agents if you look at them. So according to NCCN, which again is one of the reference, if you look, and I know it looks a bit hazy, there are very many agents that are there. And if you look at them, it's like, what did the patient have before they got castrate resistance? Then you choose the next one that they did not have, because as I said, most of these agents have crossed into castrate sensitive disease. Now, there was an interesting paper that was done that was called FAST-ANA, which then compared between cabazitaxel and docetaxel. And I think this paper had two questions to answer. One was, what was the adequate dose level for cabazitaxel, and the comparison with the then drug of choice, which was docetaxel. And they looked at cabazitaxel at 20 milligrams, cabazitaxel at 25, and docetaxel at 75, dosed every 3 weeks. And then they looked at the overall survival and the progression-free survival. And if you look at them, basically the curves look like they're mirroring each other. But the crux of the matter were in terms of the adverse events. So if you look at one of the things that we worry about, especially with chemotherapy, which is femoral neutropenia. So for grade 3 with the lower dose levels of 20 milligrams, which is for cabazitaxel, was 2.4. At 25 was 12%. That's more than grade 3. And then for docetaxel was 8.3. So if you note, then the distinction was, does the extra 5 milligrams buy you more toxicity rather than benefit? And I think that was the conclusion from the FAST-ANA trial, And that sort of set the basis for the dosing of cabazitaxel. However, when you talk to patients and you look at quality of life studies, when patients then were compared between using cabazitaxel or docetaxel as the first line chemotherapy that they get, it was interesting because then most patients then chose a sequencing of docetaxel, cabazitaxel, then abiraterone, rather than docetaxel, abiraterone, cabazitaxel. And the thinking here was in some patients, they developed already neuropathy. So if you follow with 2 taxanes, the neuropathy actually is much worse than for other, because this was patient-reported side or end point, which was the side effect, especially of peripheral neuropathy. So again, I highlight this one because it's what agent are you using? So if you had prior enzalutamide, then you're going to look towards abiraterone. If you had prior docetaxel, then you're looking at other agents. But it doesn't get that easier because we know in metastatic castrate-resistant prostate cancer, there are 3 different disease paradigms that are coming up. So for patients who've had abiraterone and enzalutamide and they are refractory to that, you have patients who have specific DNA repair pathways, and we look at that just now. And then treatment of neuroendocrine prostate cancer. I started by saying that the commonest histology is an acine adenocarcinoma, but when you have patients who have poorly differentiated disease or who have neuroendocrine differentiation, then those are maybe patients who will develop castrate resistance earlier than your other traditional patients that you end up seeing. But this then has set the basis for where a lot of studies are going into and might be the future of how we manage castrate-resistant prostate cancer. One of the things that we find, like in colon cancer, where you have mismatch repair or microsatellite instability, that might be one of the things that we need to be looking at when we biopsy cancer of the prostate, because it can predict for response to some of the chemotherapy agents that we have. We know immunotherapy in the oncology world is sort of taking shape. If you happen to listen to ASCO this year, I think 80% of the presentations were on immunotherapy. And this is because for patients who have more than expression of 1% of the PD-L1 receptor, some of these patients had a 17% overall response rate. And these are heavily pretreated patients with a median response of about 13.5 months. But then the question at the back of your mind is at what cost? Because then to have pembrolizumab for a month, I want to leave it out for what is the cost to the patient. Again, we know that some of the repair mechanisms like BRCA, ATM, and CHEK2, we have some of the agents like PARP inhibitors, like olaparib, which was confirmed that the patients actually had 100% overall response rate in people who are BRCA2 mutated. So again, now when you're talking about cancer of the prostate, maybe in the future we'll be talking about you have your PSA, you have your Gleason score, and what's your next gen sequencing signal. So do you have a BRCA mutation? Do you have a PD-L1 mutation? Do you have an MMR mutation? Then we can target those ones depending on what mutation you have, which is where we are going to precision oncology. So then, in terms of the cost effectiveness of all these treatments of castrate-resistant prostate cancer, because remember, this patient most probably has been on treatment for the last 2 to 3 years. This was done in the US. And please note this table, because you look at some of the agents and the cost per average length, which is about $93,000 US versus a survival benefit of 4.1 months. Versus something like cabazitaxel, which costs $46,638 US for an overall survival benefit of 2.4 months. And maybe this is where we then need to sit and think what gives us the biggest bang for our money. So what is the optimal sequencing for the patient? Because unfortunately, most of the times when you make decisions, it's relative to the cost of the drug that is available to the patient. Now, in Kenya, I hazarded a guess, and the pharmacist should not shoot me, but some of the costs are within sort of like NHIF coverage for some of the chemotherapy agents, some are not. So something like docetaxel, I think we have that, it's readily available in many of the oncology centers. For a while, cabazitaxel, the problem was availability, but then the cost is low. Abiraterone, this I think maybe has even come lower, but the average cost per cycle for a patient, and remember NHIF will not pay for you for all this, so you see patients are digging into their pockets. Again, enzalutamide goes to close to 100,000. Something like Sipuleucel-T is $93,000 US. I didn't put radium-223, which costs about 2 million per dose. And again, the number of cycles here depends on till the patient progresses. So in terms of canceling the patient, because they'll come and ask you, so how long do I need to be on the abiraterone? It's until your disease is responding, the PSA is responding as expected, but that I cannot be able to tell you it's going to be 6 months or 9 months, etc. So then if we think about our patients, we also, one of the things that sometimes stays at the back of our mind is that we are busy imaging and looking at the PSA, is that we need to talk about the supportive care. So bone health for patients, especially the ones who've been on ADT for more than 2 years, then we need to talk about getting a DEXA scan, and DEXA scans are not always available. So we can use CT-based bone densitometry, which can be done on CT. And again, the difference between patients who are under 70 and more than 70, we may need to, there might be a differing dosing of their calcium and vitamin D. And then sometimes we use bone targeted therapies to reduce the skeletal related events, like denosumab. The cost of denosumab sometimes restricts us. So we have IV zoledronic acid or tablets for alendronate. We need to talk to patients about exercise and weight management, because one of the things that happens when they start on ADT, they get a bit of truncal obesity. Then put into consideration that these are elderly patients who already have diabetes, hypertension, hypercholesterolemia. So to manage all these diseases in this basket, exercise and weight management, I think, needs to be at the forefront. We need to talk to them about nutritional support. And I think one of the things that has happened in the oncology centers is you have integration of nutritional services within the oncology centers. And then psychosocial support, because as we say, this patient has been on treatment for more than 2 years. Now they're getting to castrate resistant, and we're saying we're continuing with their treatment. So also support them as they're getting their treatment is very important. So I thought I should present a case, one of a gentleman I've had the pleasure of looking after. So he's PWM, a 70-year-old man who actually resides in Nairobi. And he initially presented in 2016 with lower urinary tract symptoms. On his biopsy, he had a Gleason that was scored at a 5+4. At that point in time, we did not get a PSA that was indicated. But of note is that he had hypertension and diabetes, which was very well controlled. He then, at that point in time, had a transurethral resection of the prostate and had an orchidectomy in 2016 on diagnosis, which then we can talk about whether that was the right thing to do. But in someone who had a Gleason 5+4, it might have been the right thing, because that's already quite aggressive disease. There was no mention of staging on his workup that time in 2016. So he presented to us in 2018 and 2019, sort of towards December and January of 2019, with bone pain. When he had a CT chest, he had degenerative changes on some of his bones, but on bone scans, he had those degenerative changes, and he had a lesion on T10 and on the right knee and on the right tarsal bone. So he was given palliative radiotherapy to his thoracic spine and to his ankles, and he actually did very well because the bone pain disappeared. Now, based on that TAPS 327 trial that we looked at, he had 10 cycles of docetaxel and prednisone, and he was doing very well. A year later, in 2020, he was noted that his PSA was rising, his testosterone was within castrate levels, and he was started on abiraterone at 1,000 milligrams twice a day, together with Zyphos, and I think there was prednisone there. My apologies for that. He did that for about 9 months. He sustained a fracture of the right humerus, and the humerus was pinned, and he got palliative radiotherapy. But he was noted that his PSA now was starting to rise again to 88 nanograms per ml, and he was started on Casodex, or not the traditional 50 milligrams, the higher dose of 150 milligrams. We can discuss why the higher dosing and what is the effectiveness of that. Again, seen in January 2021 with back pain, he had lower limb numbness, he had hematuria, he had suprapubic pain, and he had a headache. Of note at that point in time was his PSA was 157 nanograms per ml, again, the rise from 88 prior. He had an MRI that still showed the degenerative changes that we had seen before, but there was no evidence of metastasis, interestingly. When we examined him, he had tenderness over the spine and the pelvis. He was discussed at the MDT, and a recommendation for him to get a PSMA PET, and then we consider enzalutamide with continuation of his Casodex because he had progressed. So for those who maybe have not seen a PSMA PET, this is what it looks like. So for him, he had malignancy in the seminal vesicles, which is here. He had pelvic adenopathy. He had multiple nodes sort of in the retroperitoneal area, and he had liver disease, as you can see there. He had multiple skeletal mets in the skeleton. So if you see all the dots here and up here, which are the nodes. And of course, he also had disease on his sphenoid wing, which was in the brain. That was classified as a clinical T4, N1 disease, M1 with visceral metastasis. So his plan at that point in time was to give him radiotherapy to his cervical C7 thoracic vertebrae, his lumbar spine, and his pelvis. And again, please note that the PSMA PET picked up the bone lesions. The MRI did not, because it was reported as normal. While he had just finished his radiation, he developed poor vision on the left eye. And remember, he had the mass on the sphenoid wing. So when we scanned him, he had this mass at the orbital apex that was compressing the optic nerve, and he received palliative radiotherapy to the crania. So I think he's resting and waiting to come start on his enzalutamide. So my thoughts were, was this maybe the optimal sequencing of therapy? Now, remember, this man was diagnosed in 2016. So he actually had a full 2.5 years before he actually got to the place where we say he's castrate resistant, which is in keeping with what we know from literature. But the other thing was, should he have had that orchidectomy upfront? We can argue about it, but it's one of the ways that we use to have androgen deprivation therapy, either by using Zoladex or orchidectomy. For most patients, orchidectomy is not agreeable to them, so they will refuse. Again, the sequencing of using Casodex later on at a dose of 150, we can discuss about that, because I know there are some people who will use that in some of their centers. So if we're thinking about how to manage cancer of the prostate, is that we must be science, we must be evidence-driven, but the biggest focus must be on the quality of life issues for men and their families, so that we are not, I don't sit in the unit and I'm like, we need to get enzalutamide, and the patient cannot afford it. I'm sure there are other things that we can be able to offer the patient that will not change their quality of life. We must always continue to improve the supportive care interventions. So like things like integrating nutritionists, integrating occupational health and physiotherapy, of course, as we hope for a cure for this disease. So in conclusion, I think the PSA doubling time becomes the most important thing when you are stratifying patients for non-metastatic castrate-resistant prostate cancer. And I cannot underscore that the androgen receptor still remains one of the biggest drivers we'll have, even in the continuum of the disease and management of the disease. And that treating prostate cancer for patients feels actually like a marathon. So you must make the most mileage out of each therapy. There is more than one right way of sequencing the treatment, which is why we discuss patients at the MDTs. And we also always want to understand what is available to the patient, what can the patient afford. And sometimes cost will dictate therapy, which I think in our practice every day, that has become sort of commonplace. And again, cost is to remember that cost might not be the monetary terms, but also the side effects that the patient gets from the treatment. Thank you very much. Thank you for listening.
Thank you. Thank you so much, Dr. Njoki. That was a very informative presentation, very detailed. Shukrani sana. Thank you. I can see a few questions on the Q&A tab. You can feel free to answer some, although we'll have the Q&A session where you can address the questions live so that everyone can get something from the questions. Next, we're going to have a presenter from Glenmark, Bernard Kipyegon. Are you with us, Bernard?
Yes, sir, Ratema, yes. I'm
yes,
just sharing my screen.
Karibu sana, Bernard, asante.
Thank you. Good evening, everyone. Welcome to this short presentation from Glenmark. Once again, thank you very much, Dr. Njoki, for that elaborate presentation on the topic, well detailed. It's my pleasure to introduce to you Glenmark in the new era. Glenmark, we have a global presence, and we are operating in more than 80 countries, and the key markets include USA, Europe, Asia, India, and even Africa. We are also very much engaged in innovation. We have 8 novel molecules at various clinical stages of development, and of niche interest is focused on therapies like oncology, hormones, and complex generics. And today, Dr. Njoki has really talked so much on abiraterone, and mine is just to introduce our brand of abiraterone called Abrapro for the management of prostate cancer. And we are saying, keep their passion going. It is indicated in combination with prednisolone for patients with metastatic castration-resistant prostate cancer and metastatic high-resistant castration-sensitive prostate cancer. So Abrapro 250 mg is available for this patient. And in summary, as I've said correctly, it's indicated for metastatic castration-resistant prostate cancer and metastatic high-resistant castration-sensitive prostate cancer. What is very important, as rightly mentioned by Dr. Njoki, is improving the quality of life of patients. And with the use of Abrapro, the quality of life, which is the benefit we are giving to the patient, as compared to, of course, we've seen, as rightly mentioned, that the duration of survival rate with abiraterone, that is Abrapro, is quite longer as compared to other therapies. And of course, improvement in pain and delay of skeletal-related events. That is the benefit Abrapro or abiraterone offers to our patients. And it gives me also pleasure to introduce to you ICANN program. This is Individualized Cancer Support Access Program for patients. The program aims at supporting eligible patients to ensure access and adherence to treatment with Abrapro medication as recommended and prescribed by doctors. So we have this particular program just to help our patient to access affordable medicine and to support them through their journey as they battle with their prostate cancer. So Abrapro, as rightly mentioned, is whenever it comes to prostate cancer, the drugs are quite expensive. And we are privileged to have Abrapro, which is quite affordable and offers sustainability in terms of being able to have our patient access this brand, Abrapro, for quite a long time to ensure that we are restoring hope for our patient. The program again enhances patient engagement, enhances compliance and access to the medication. We are also in partnership with NHIF to ensure that our patients are able to access 3 months of Abrapro, that is our brand of abiraterone, with their NHIF card. So that is the benefit we are offering, 3 months of access of medication for our patient. And of course, this program helps our patient to ensure that their journey is really assisted and made, giving them hope. And of course, door-to-door delivery is also there for the patient, and even regular follow-up for the patients and being there in psycho-support and counseling part of for the patient and even for the family. Even though the patient, we are counseling and we are giving them this psycho-social support, we are also ensuring that the family is able also to benefit from this. How can a patient enroll to this particular ICANN program? Upon diagnosis and whenever they are being prescribed Abrapro, the physician or the doctor may be able to inform the patient about our program, the ICANN, and at that particular point, they can also get to know about this program through the ICANN, the brochures. And by the willingness of the patient, they can enroll to this particular program with permission from the doctor and the patient. Then they get enrolled to this particular program. So with that, I say thank you. And of course, the patient consent form, which needs to be signed whenever we are enrolling the patient to this particular ICANN program. The benefit we are seeing is the cost affordability for the patient, as we are aware that this particular therapy for prostate is quite draining. So the benefit of price and affordability and quality we are offering from Glenmark in our brand Abrapro. So thank you very much. Asante sana.
Thank you so much, Bernard, for the wonderful presentation. Very informative. So I have a few questions for both you, Bernard and Dr. Njoki. Dr. Thank you so much for the presentation. It was very detailed. Asante sana. So I will pick some questions from the Q&A tab. The first question comes from Dr. David Water. He said he has seen prescribers who give the LHRH agonist plus Enzalutamide and Abrapro, and even after progression, they still, after continuation, he asks what the rationale is considering these drugs. What's the rationale in considering these drugs, even though they helped initially, but they are no longer currently helping? Shouldn't Abrapro be without the LHRH agonist and Enzalutamide?
Yeah, and I think that's a very valid question. Thank you, Dr. Wata. So remember when we talked about that continuum of patients who, when we start off, they actually have castrate-sensitive disease, which means we are using androgen deprivation therapies as the modality of treatment. So for many of these patients, if they are non-metastatic, they need to be on. So let me maybe define a few terms. So androgen deprivation therapy means you're giving your LHRH agonist, which in our setting, commonly the patients get Zoladex. It's given at a dose of 10.8 milligrams subcutaneous on the anterior abdominal wall every 3 months. I know some people who use the 3.6, but I think the cost to the patient is much higher than using the 10.8. So for cancer of the prostate, we'd like to go for the 10.8. Now, when this patient then gets metastatic, they are still castrate sensitive. We add the Enzalutamide, so which is now the combination of the LHRH agonist together with the androgen receptor blocker like Enzalutamide is called complete androgen blockade, which is recommended for patients who have metastatic disease that is castrate sensitive. Now, when the patient crosses the threshold and they get castrate resistant, then we need to drop the androgen receptor. Remember, we said we still have some of the tumor cells that are responding to the hormone-dependent pathways. So ideally, we should keep the LHRH agonist on, then you add your Abrapro, but not the combination of your Zoladex, your Enzalutamide, or whatever agent you're using, which commonly in our setting is Casodex, and Abrapro. I think there's no rationale for using all three. So ideally, it should be the LHRH agonist continues, and then you add on your Abrapro, but take out the Enzalutamide or the androgen receptor blocker.
Okay, thank you so much for answering that, Dr. The next question is, someone has a patient on Abrapro and they're conflicted between using the original brand and the generic brand. Is there any clinical significance of using either of the drugs?
So I'm not the pharmacist, but you have, so in oncology, we have things that we call biosimilars. And I think as pharmacists, you're better placed. You see, the thing with development of drugs is if you have the originator product, they are the people who had the patent for a long time. They're the ones who developed this agent. So then they will market their drug as the originator product. However, I think in our market, we have very good generics. And I think the biggest drive has been in terms of cost for the patient. Because then if you look at some of the originator products, the cost is now what will come to like 50,000 or 95,000 for a month's dose of Abrapro. Vis-a-vis using some of the generics that have been very effective, they have good safety data. So I cannot sit here in my professional capacity and tell you that you should use this agent. I cannot prescribe that. But I think you have to do your homework in terms of what generic are you prescribing for the patient. Again, there's not been any head-to-head comparison of an originator product and the generic. So I cannot tell you that there's evidence for that, but there are very good generics in our market that you can use for the patients.
Okay, asante sana daktari, well answered. Dr. Amudwai Joffrey is asking, at what point do doctors consider giving Zoladex 10.8 mg to 3.6 mg? Yeah, so it's what I was saying. I think in cancer of the prostate, I would say it's uncommon that we use the 3.6 milligrams. And even
For patients who are getting like ovarian function suppression for CA breast, we traditionally will use the 10.8 milligrams. I'm yet to come across where any guidelines talks of the 3.6, unless you're now managing things like endometriosis or something like that. I have not come across the 3.6. So unless it's to do with availability, most I think would recommend to use 10.8.
Okay, thank you, Dr. The next question is from Dr. Dr. Anthony Mbugwa. He's asking, is there any benefit in checking for genetic mutations of the androgen receptor in cases of resistance or in anticipation of resistance?
Yeah, so that's what I was saying, that for patients who have castrate resistance, as I said, when you're looking at now precision oncology, one of the things that we are now might come into standard clinical practice is looking at androgen receptor mutation. So the commonest one that we have is the variant, splice variant 7. So it's called ARV7, which is the commonest mutation that we have in the androgen receptor. Now for patients, especially where you have things like poorly differentiated tumors, anaplastic type, it's one of the recommended things that we need to be doing, because then these are patients who we already can predict that they will have more aggressive disease, and we should be testing for that. Now, for now, as of now, we are not doing it at the time of diagnosis, but at the time when patient gets castrate resistance, then there are centers that are biopsying the prostate so that you can get new tissue to do now both the next gen sequencing to look for things like MMR, BRCA, ATM, CHEK1 or CHEK2, together with the androgen receptor mutation, because then some of the therapies that are coming up will be directed at patients, or you divide the patients into those ones who have the androgen receptor splice variant 7 mutation or not. So it's something that is, I think, going to come into clinical practice maybe in a few years.
Okay, thank you, Dr. The next question is from Dr. Eric Amolo. He asks that in one of your presentations, he noticed the dosage for abiraterone on a case was 1000 mg/d. And was it a special case, or does it have any benefit over the recommended 1000 mg OD?
Thank you, Eric. I was having fun with the presentation. So the patient didn't have 1000 milligrams BD, it was OD. Thank you for picking that up, because the correct dosing for these patients should be 1000 milligrams once a day.
Yes, thank you, Dr. Eric, for being very keen. The next question is from Dr. Linus Wafula. He asks, this I think is directed to Bernard Kipyegon. What's the cost of Abrapro per course?
Okay, thank you very much for that particular question. As I had mentioned earlier on, we have a partnership with NHIve, and normally NHIve approves 120,000 for our patients. So with 120,000, your patient is assured of 3 months course of Abrapro. So again, from hospital to hospital, we cannot really dictate on how much they give. It varies from hospital to hospital, but in the range of 40,000 to 50,000. But for NHIve, yes, with 120,000 approval, they can benefit, they get the benefit of 3 months cycle of Abrapro. So thank you.
Asante sana, Bernard. The next question is from Dr. Anthony Minor. First, he says, thank you, Dr. Njoki, for the informative presentation. Question number 1 is, his patients are doing well on docetaxel. What's the best way to handle fluid retention? And question 2 is, when do we consider using DES in MCRPC? Kindly comment.
Thank you. So I thank you, because patients actually tolerate docetaxel very well when they're getting it for cancer of the prostate. Interestingly, I'm not really sure what happens, but the fluid retention that occurs is one of the side effects that we get with docetaxel. So one of the recommendations is that for patients who are getting docetaxel, we start their steroids the day before, the day that you give the docetaxel. So it's like the night before, and you ideally need to dose the dexamethasone at 4 milligrams BD the day before the docetaxel, the morning of docetaxel, and they continue till they finish another 2 days after the docetaxel. That helps. But the other big thing I find is that with docetaxel, most patients tend to pre-hydrate and post-hydrate the patients. And if you look at any of the guidelines in terms of making the chemotherapy for docetaxel, pre-hydration, you actually need to fluid restrict the patient, because what happens is the nurse will run the pre-hydration as standard, like you're giving something like cisplatin, while they actually don't need to be heavily pre-hydrated and post-hydrated. So fluid restriction can be one of them. One of the centers I've worked in, they used to recommend that patients, so that they can be able to pee a lot, they actually prescribe them to have some little coffee or tea, so that they can actually have a diuresis effect, but the steroids usually work well if you start them before the day you give them the docetaxel. Then thank you for asking about diethylstilbestrol. So the good old diethylstilbestrol has been with us for a while, and we've used it a lot, I think, before we had any of the agents like Casodex or abiraterone or enzalutamide, or even docetaxel in cancer of the prostate. So it's a good drug, but I think where it got a bad rep was because of the issues with thrombosis and pulmonary embolism. Now, it doesn't mean that to this day we do not use it, because, for example, our patient who has gone through docetaxel, has had abiraterone, has had bicalutamide for a while, and now we're thinking of enzalutamide. If they can't afford it, then what you are left with is either rechallenge with rechallenge with docetaxel, my apologies, or offer them cabazitaxel, or you give them diethylstilbestrol. So it still has a role, but because of now the availability of the newer agents, we are not using it a lot in clinical practice because of all the other side effects or the bad rep that it got, but it still has a place in terms of managing metastatic castrate-resistant prostate cancer. I also find patients who maybe might not have access to an oncology center, the urologist will start them on the DES, and they actually relatively do well, apart from some of them who will still get the side effects, especially thrombosis as the biggest issue. So we still use it, but not as commonly as maybe we did a few years back. Thank you.
Okay, thank you so much, Dr. The next question is directed to Bernard. Bernard, Dr. Samuel asks that it is not clear how patients can enroll in the ICANN Access program. Would you like to recap that part and kindly leave your information on the chat box so that they can consult you further on the issue?
Thank you very much for that particular question. Yes, through ICANN program, upon a patient is diagnosed with prostate cancer, yes, with the consent of the doctor and the patient, they can enroll through this particular program. We have our representative across the country who meet our doctors, and the oncologist, the urologist, we are in contact with them, and through them we are able to have this particular enrollment, because we cannot really enroll the patient without the consent of the doctor. The doctor has to really agree, because much of it is the support which you're giving is just the support, but we have to have the consent of the doctor. So across the country, we have our representative who are meeting the oncologist, who are meeting the urologist to ensure that this particular program is available to the patient. Yes, we will be leaving our contacts in the chat box so that for further engagement and for further, we can know where you are, then we can send our representative to where you are to ensure that your patient get benefited with this particular program and also with our abiraterone, Abrapro. So thank you very much.
Thank you so much, Bernard. Dr. Mugambi Ibui first says, Dr. Njiriani, well presented and very informative. Can you comment on early detection of prostate cancer? Specifically, what are the detection methods used now?
Okay. So thank you for that, and hi, Dr. Ibui. So one of the things is that as long as you're a man, you have a prostate gland, you are at a risk of developing prostate cancer. However, this risk starts from the age of 40, and this is because from the time someone is a teenager, you start producing testosterone, and unfortunately, you'll produce this testosterone, or fortunately, you'll produce this testosterone until maybe you're 90. Now, this constant stimulation by this hormone testosterone can stimulate your prostate your prostate cells to start increasing in size, which you develop something called benign prostatic enlargement, which was then called, or benign prostatic hypertrophy as it was referred to before. But during that process of the cells now growing bigger, you can also develop a focus of cancer within the prostate. So the current recommendation is that if you're a man in Kenya above the age of 40, at your 40th birthday, you need to reward yourself by a visit to the doctor, where the doctor will explain to you the risks versus the benefits of doing prostate cancer screening. He will give you information on what will happen after you get your PSA. He will give information on that he needs to examine you. He needs to examine the prostate gland, either by using a digital rectal examination or an ultrasound. So the current recommendation is that there are 3 tests that you do. One is you get well informed, you get a clinical examination, plus or minus an ultrasound, and you get a PSA test. Now, if your PSA, depending on your age, there's a PSA threshold for each of your ages, then the doctor will recommend to you how often you need to be doing that PSA. So that is how we detect prostate cancer early. I know some people in the West who've been doing, because they can afford it, they will go and do an MRI of their prostate, because there's what you call a PIRAD scoring system, which can determine whether there's any lesion within the prostate. So if you can, well and good, but still the PSA test becomes one of the key tests that we do. I want to clarify that the PSA test is a quantitative test, not a qualitative test. So you find people who go and get a strip that reads positive, like the way you do a pregnancy test, this is positive. So as long as you're a man, you have a PSA read. So we actually need to get a number so that you get a figure that then correlates that you have a PSA of 1 nanogram per ml or 3 nanograms per ml. And then that can act as your baseline from the age of 40. Of course, things like watch your weight, eat enough vegetables, eat enough tomatoes, all those nutritional things can help. But then your risk of getting prostate cancer just by virtue of you being a man is inherently there. Thank you.
Okay, thank you, Dr. Our second last question comes from Dr. Hilary Ruto, who asks, how long should one take the drugs, and how long should a patient take Casodex? Those are 2 questions.
Yeah, so I think, Hilary, the question is what drug? So remember when I highlighted that for patients, especially once you've started the cancer journey from the time of diagnosis, most of the time you'll be on your androgen deprivation therapy. If you're having radical treatment, your androgen deprivation therapy is for 3 years. Before it was 2 years, now we have evidence that 3 years, the patients actually did better than for 2 years. So now the current recommendation for getting your goserelin is 3 years. That is if you're having surgery or you're having radiation treatment. If you have metastatic disease and we are doing complete androgen blockade, we will continue with the combination of goserelin together with your bicalutamide, whatever you have, or Casodex, until your PSA shows that it is rising. So you're getting to the place where you're getting castrate-resistant prostate cancer. In that case, if, for example, we had introduced something like abiraterone before, which is happening now for the patients, your PSA and your imaging is what will determine how long you're going to continue with that, because you're going to continue with the medication until disease progression. So for Casodex, I won't tell you it is 3 years, no, because you have metastatic disease. Until your PSA starts to rise, that's when you will stop it, or the abiraterone or the enzalutamide. But for goserelin, that's what you take for 3 years for those patients who are treated with radical intent. If you're metastatic, it's until you get castrate resistance. We will continue with your goserelin and add on something after that. And then Ivy, I see a question from, I think it's Dr. Winnie Mwangi. So she's seeking clarification on combination of 2 androgen receptor blockers, that is enzalutamide and bicalutamide, as seen with the presentation. So those are, again, some of the things I was highlighting, that if, sometimes you feel like you need to do something for the patient, so you need to put them on some therapy that seems to be working. But again, the combination, as I said, same with the abiraterone, for patients who progress, you need to keep them on the goserelin, because that is what is giving your androgen blockade. And then now you add your second generation androgen receptor blocker. So your bicalutamide would be your first generation, your Enza is your second generation. So you cannot combine the 2. It's one or the other. Thank you.
Okay, thank you so much, Dr. The next question I can see has been typed on the chat box by Dr. Aaron Mungira. He asks, what proven prostate cancer prevention measures could you recommend? How can we prevent prostate cancer?
So that's a good question, and I will not pretend that I know. So that's why I say that as long as you're a man, you need to be aware of your prostate health, and that starts from the age of 40. Before that, so there are things in cancer we don't talk of one-to-one. Like if you have Mycobacterium tuberculosis, you get TB. It is not a one-to-one. So they're what we call risk factors. So risk factors are the things that will increase your probability of getting cancer of the prostate. For example, having multiple sexual partners can increase your risk of developing prostate cancer. Having multiple urinary tract infections, prostatitis, because all this cause inflammation, and during that inflammation and healing process, and it's repeated over and over, your cells are trying to repair whatever damage has been there. That is one of the risk factors. Having STIs can increase your risk of developing prostate cancer. So we let's maybe divide them into what are modifiable risk factors and non-modifiable risk factors. So the other modifiable risk factors are being obese, not having a high fiber diet, lack of selenium, lack of exercise, alcohol use, cigarette, all the things that you know from risk factors for cancer. Now, the non-modifiable ones are the ones that you can't change. So if you have a family history of prostate cancer, like your dad or your brother or your uncle had prostate cancer, then you are at a slightly higher risk than the general population for developing cancer of the prostate. So depending on what age your first degree relative had cancer of the prostate, your screening ideally needs to start between 5 to 10 years earlier than that. Now, luckily for most of our patients, you get diagnosed with cancer of the prostate in the late 60s or 70s, which is still way later. Even if you put 10 years earlier than that, you still get to the 40. So 40 is the time that we need to start looking at your prostate health. So there's no one thing you do to reduce your risk of prostate cancer completely, unless you go get your prostate removed, then nobody wants that. So you just need to have to start screening at the age of 40. Thank you.
Okay, thank you, Dr. This is the last question. I'm sure we have burdened you with questions. This is the last one from the chat. Dr. Aaron Mungira asks, what are the common interactions with other common used drugs such as ARVs, antidiabetics, antihypertensives?
So I gave a caveat in the morning. I'm not a pharmacist, so I may not be the one. So one of the things that you'll find with cancer patients is that you end up practicing polypharmacy. So it's like you have to sit and then look at what are some of the drug interactions that you get. So things like abiraterone, because of some of the side effects that they cause, you can get some of the interactions are not actually to do with the drugs themselves, unless it's a specific drug that we're talking about. For patients who have HIV and are antiretrovirals, if they're virally suppressed, ideally we manage them exactly the same like someone else who is not HIV positive. The interactions now with the newer ARV drugs, I want to confess that I may not have looked that up, and maybe I need to. In terms of the diabetics and antihypertensives, I have not come across that. I may also need to look up. But the biggest thing that I know is for patients who are, especially when you've been on ADT for a long time, things to do with high cholesterol becomes an issue. Sugar control can become an issue because patients gain weight. And then because of either the fluid retention or the chemotherapy that they are getting, their pressures can go up. So you also have to manage the patient as an oncologist, not in isolation, together with the patient's physician. But I think it's an interesting question. Maybe I can also read up about it. Thank you.
Okay, thank you. Thank you so much, Dr. Njoki, for the wonderful presentation. I can see so many people requesting for the document. The presentation will be availed to us from Dr. Njoki. Thank you so much. The presentation will be uploaded on the PSK website, and the webinar is being recorded. It will also be posted on our YouTube page, the PSK YouTube page. Thank you so much, Dr. for the informative presentation. We are eternally grateful. To Bernard Kipngeno, thank you so much for your presentation on Glenmark. I have seen you've left Bernard has left his contact on the chat box in case anybody needs to get in touch with Bernard, and Duncan Evans also from Glenmark. You can contact them for more information on ICANN. Last but not least, I want to thank all of you for participating today. I would like to invite my colleague, Dr. Mbau Gitao, who's joined us. I'd like him to give the closing remarks. I have been Ivy Ratemo. Thank you all and good night from PSK.
Asante. Thank you very much, Ivy, for the wonderful job you have done tonight. Asante sana for the wonderful moderation. Our esteemed members and seniors of the Pharmaceutical Society of Kenya, as Ivy has well elaborated, that all these recording, presentation, this whole webinar is being recorded and shall be uploaded to our website on the PSK page, that is Pharmaceutical Society of Kenya, on YouTube. Receive our greetings from the National Governing Council, first and foremost from the President of the PSK, that is none other than Dr. Louis Mashogu, and from the Secretary of NEC, that is the Head of Secretariat, our wonderful CEO, Dr. Daniela Munene. Ladies and gentlemen, thank you very much for joining us. We meet on Thursday. We meet on Thursday evening for another webinar. So without further much ado, allow me to pass our sincere gratitudes from PSK to Dr. Njoki Njiraini. Asante sana, Daktari, for taking your time to take us through the wonderful topic of prostate. And Bernard, asanteni sana, Glenmark, for sponsoring us this wonderful evening. Without further much ado, ladies and gentlemen, let me wish you a good night. Tunasema kwamba lilo na mwanzo lazima liwe na mwisho. Hatuna lingine ila kusema alamsiki. The webinar is on the PPB portal. Ensure that you subscribe by today midnight. Asanteni sana, muwe na usiku mwema.